we're now going to ask Stephanie and Jim to come up, and we will have a panel discussion. So it is now open to question time, of which I'm sure it's always one of the best parts of this event. We get to really, you know, ask our questions that we've had. And over time, obviously, that sort of builds up with our own experiences, but also what you might have heard tonight. So if you can maybe put your hand up if you would like to ask a question, and aim it towards one of our wonderful experts up here, and then we will go from there. We don't have a microphone this year, so if you can sort of speak up fairly loudly, that would be fantastic. Thank you.
Any first takers?
So is the condition hereditary?
Not all cases, it's complex. I think maybe about 10% of cases of keratoconus might have a strong hereditary component. There's lots of teams around the world looking at the genes of keratoconus, and it's quite complex. So yes, but not in all cases. I do say that if you're a parent with and you've got young kids with keratoconus, it's probably good that they have an eye test when they're about 8 or 10, and then probably 12. Something like that.
Yeah,
So,
I have 3 kids, so that was better.
yeah, well, especially through puberty, because keratoconus seems to be an eye condition that really develops through puberty. So, like getting a kid checked at say 4 for keratoconus is probably not going to really get any result. But you know, probably after 10 in my world anyway.
yeah, I mean, I have seen some quite young cases. That's why I was sort of saying 8. I have seen kids as young as 8. So, and it gives you sort of the baseline data for then if they're going to develop it later.
Were they allergy prone, those young kids as well?
No, but I have seen younger kids with the allergy. You know, does make you more likely to get it or for it to get worse. Yeah.
So you talk about seeing an optometrist who's a specialist in this.
You can't call them that.
Well, optometrists who've got a lot of experience.
Yeah, that's better.
Okay.
You're quite good, but you know, I've got friends who live a bit far away, can't get to the city. Is there a registry, or is there somewhere that we can look up and go, hey, this optometrist is more experienced in this area than another?
Yeah, it gets a bit political. One of the things I do know, though, is that most of the contact lens fitters that have got experience tend to be in capital cities. And it's only because of volume. One of the things I do know for a fact is that it doesn't matter how smart you are. If you don't do things enough times, you don't get good at it. And some people say this about me, is that it doesn't matter how dumb you are. If you do things a lot, you get better at it. So, you know, it is. And because cities have big volumes of people, they tend to go there, and therefore you get more experience in cities.
Surely there must be, like, you know, in some of the areas like Parramatta or...
Oh, you're talking about...
area,
yeah.
A little bit further away from the city.
You'd be surprised. I think there's 3 in the CBD, and that's about it.
Can I put my 5
Yes.
cents?
Yeah.
Sorry. Larry Kornhauser of Keratoconus Australia, I came across him because I wanted to ask a lot of questions as a patient, and he can suggest people. He's not an expert in as far as being a specialist, that we're not allowed to say, but he deals with us on a patient-to-patient basis. He's someone who's gone through keratoconus, multiple operations, you name it. He's been with Keratoconus Australia for so many years now. And I would say, as a first port of call as a patient, I would definitely be sending him an email or sending the organisation an email, and they will get back to you with information as well. Yeah.
Jim's great. You know, I've been seeing
He's looking around.
I get the file in there.
but not everybody can make it.
No, I get that. Yeah.
Look, it is difficult, but, you know, I mean, I think it is something that does require, you know, a lot of repeat work. Can't say specialisation.
Try.
Hi, just a question on when you sort of diagnose at an early enough stage. Is it true? Because I've actually had it for about 30 years, so I'm pretty familiar with it. I'm sorry if I'm late, somebody's already asked this question before, but if you tend to wear hard lenses or some type of lenses at an earlier stage, does it tend to hold the eye together better? That's what we heard sort of decades ago. If you do put a lens in, a particular thing, a hard lens or something that holds the shape, is that true at all?
It's a myth.
It's a myth.
In fact, it can progress the problem, because if you put excessive pressure on the cornea, you'll end up potentially damaging it. In my experience, anyway.
I mean, it is hard, and that's why when we did our review and went to the literature to try to find studies that could inform on these sort of questions, and we wanted to find out, well, if you're going to check someone's vision, how long before should you take contact lenses out? And there's not a lot of great data out there to answer some of these sort of more nuanced questions.
Are the rates the same between male and female in the community? I know a lot more males than disease than females. What are the rates in comparison?
I'll let Stephanie.
I mean, the rates vary around the world and with different groups. And so the Maori patients have very high rates of keratoconus, really high rates. There's a recent study published where I think they said 1 in 50 kids in primary schools in New Zealand might have keratoconus. And in countries where it's very dry or there's lots of allergy, also there's this effect with sunlight. And so it does kind of vary on a sort of a population basis, but I think it is more common in males.
Yeah. Would you agree that young males have more allergy than young females? Eye allergy, I'm talking about.
Yeah, I think they have higher rates of vernal keratoconjunctivitis. That's severe allergy.
As a small child, when I was younger, I had a lot of conjunctivitis growing up. Got an immense amount of for a long time. Would you think that would be a factor?
Possibly, especially if you were rubbing, which you probably were.
I mean, the whole eye rubbing thing is very interesting. Nobody can do sort of a randomized trial where they make one group rub and another group not rub, and then see who gets worse keratoconus. But there's kind of various anecdotal evidence of like people with, with their right hand being their bigger rubber hand getting worse keratoconus in that eye. And so we think there's a link. We've added it in our registry. We're actually collecting that information on eye rubbing from patients and allergy at the moment to try to help inform a bit more about that. So if you do have recurrent conjunctivitis, you probably weren't touching the eye, and it's not just sort of rubbing like that. We think it tends to be sort of more knuckle rubbing or harder rubbing. And then, we did a campaign a couple of years ago with Keratoconus Australia, and Larry was very, interested to try to tell people to stop rubbing. And when you rub your eye, it actually does lower your heart rate a little bit. So it's a little bit relaxing. So some people rub their eye, not even because it's itchy, just because it's like a habit they've got into. And so I had a patient the other day, and he said, look, I've solved the problem. He's a young kid, I think he's about 17, 18. He said, I've asked all my mates if they see me to rub my eye to tell me to stop rubbing my eye, because he couldn't trust himself from stopping to rub, which is very useful.
Question from the webinar.
Yeah.
Jim, given that the fit of scleral lenses and the ability to wear them relies on the solution you use, how do you go about choosing these as there's so many options?
The cleaning solutions.
I think so, yeah.
Yeah. Okay. So the first thing you have to take into consideration is disinfection. So there's various solutions that you can use there quite successfully. You don't have to use hard lens solutions for scleral lenses. One that I like is one called BioTrue. It's actually designed for soft lenses, but it actually wets scleral lenses brilliantly. The key to successful scleral lens wear is, in fact, putting the lens in with preservative-free lubricant, whether it's saline or whether it's some sort of eye lubricant. It must be preservative-free, because the solution actually sits on your eye and sits there all day. And if it's got preservatives, you'll potentially get a toxic reaction to that. So I think that's probably the best advice. Preservative-free solutions for insertion.
All the plungers and what you use for cleaning, you should put it in warm water.
No. Well, if you're cleaning it with a detergent, firstly, sometimes it's difficult to get the detergent off. You're better to buy a cheap saline, even if it's preserved, that's fine, and rinse it off with that. Then on the insertion, put preservative-free saline in for when that's what's going to actually contact your eye.
Sorry, about the eye rubbing. So my understanding is virtually all cases of keratoconus affects both eyes. Does that mean people are equally rubbing both eyes, or do they rub one and it just happens to affect the other?
Look, you don't have to rub. I've got patients that have never rubbed their eyes that have keratoconus.
Yeah.
Also, you can have really quite asymmetrical keratoconus, and I've seen this, you know, particularly in young kids, where one eye is pretty well normal and the other eye has really advanced keratoconus. And so it's not necessarily a symmetrical disease. So the eye rubbing story, it's you know, we think it's related, but we don't know how, who, you know, whether it's just some people that are predisposed to it. So it's not a necessity, because sometimes, you know, people, if that message, we're trying to get the message out there to stop people rubbing. But for the people that have got it that haven't rubbed, they're like, well, what did I do? You know, was I rubbing in my sleep, or, you know, and so sometimes I have to say to people, don't worry, you know, you didn't rub, you didn't do anything. Yeah, something we need to know more about.
If you've had a graft, you still have keratoconus in that eye?
Yeah, so after you have, so keratoconus, you know, when we do a graft, we leave behind a rim of normal tissue to stitch the graft into, because we don't want to stitch the graft into the blood vessel section of the eye. And that rim can get, because keratoconus can advance over time. And so sometimes what you see is a graft that's been done many years ago, sitting sort of in the center and this ectatic area, stretched area around the edge. And so the keratoconus has progressed in that eye despite the graft. You can also get, it's a bit like a table with weak legs. And so in keratoconus, the legs are still a bit wonky, but you're putting a new tabletop on. And for some people over time, those legs don't have enough support. And so the table looks like it has keratoconus, even when the graft is a normal thickness.
So is the failure of graft an advancement of the keratoconus, or that's just the body rejecting it?
Yeah, so the 50% is the overall sort of graft failure rate. For keratoconics, the outcomes are a bit better because they generally have them when they're young and they don't have other blood vessels and things. So they're sort of the 20-year survival for a keratoconic graft is something like 92%, 90%. But the reason they fail is 20% of grafts can reject, but most rejections can be treated. So they can fail from rejection. They can fail because they can't give a good focus. They're sort of some of the common causes of failure. So failure in that it's either, because when you get a graft, it comes with a certain number of cells, and we're all born with a certain number of cells on the back of the cornea in our lifetime, and those cells drop off after a graft. And so over time you lose those cells. You lose more if you have rejection. So it just that it stops working.
And so what are if it's the possibility of treating it through rejection, what are the early signs you need to?
Red, sore eye, blurry vision. You need to come in. I had a patient, I did a graft in December and she didn't come, she sort of stopped coming for follow-up. Came in the other day, a week of poor vision, red eye, blurry vision. Unfortunately didn't sort of come sooner, but nonetheless we started the treatment. It's actually reversing the rejection, but the sooner you get in, the better chance you have.
Yes. Sorry. I've had it for like 20 years. I wear hard lenses and sunglasses. Is there an age when you shouldn't have or can't have the cross-syncing or a graft? Like, what's the next step? Like, I'm getting to the point where I'm in front of a computer most days, and my eyesight, I'm squinting still. Like, my eyesight's going.
It depends whether your cornea is scarred or not. So if you've got corneal scarring, well, that potentially pushes you into a corneal transplant, because really fitting another contact lens on top of an already foggy windshield, if I can call it a windshield, is really going to... That's the next step, yeah, corneal graft, yeah. But if not, you're better, in my world anyway, to persist with the... where you are, because you have a corneal transplant, and a lot of those people end up either with pretty thick glasses or scleral contact lenses. So you end up back to square one again. So if you can avoid a graft, it's better. But if you have to do it, you have to do it. Like, that's as simple as that.
Like again, the hard lenses will contain it.
Yeah, it doesn't. No.
The other thing is like, when you get to a certain age, you kind of need reading glasses. And so people with keratoconus also go through that sort of age change. So, so as Jim says, like, go and get your contact lenses looked at, get your glasses looked at, make sure they're up to date.
Yeah.
And cross-linking only if your keratoconus is getting worse. So it may not be your keratoconus that's causing you troubles, or it may be the scarring, and that cross-linking doesn't work to stop scarring. No. So it's really getting an assessment and getting glasses, contacts updated.
And my optometrist should be able to tell whether I've got scarring. Like it's normal.
Oh, the practitioner should be able to tell you that straight away. Yeah.
I'm just wondering, out of all the people in the room here who've had, say, for at least 2 decades, or like me, I've known for 3 decades, what's the proportion of people that find it's actually getting worse, or have you had to check regularly to see if it's getting worse? Because I've been told mine's now stopped for quite a while now, so I'm just wondering what the consensus of people who've had it for a long time. Has it stopped for them, or
They say it's slow.
Yeah, they're saying it's that's the same way they said it's slow, but now they're saying it's virtually stopped. So they found that I haven't changed my.
I've seen a number of occasions actually reverse. Believe it or not. Now, I can come up with any theory you like about that, but I think the cornea naturally cross-links as we age, and to a certain degree, I've seen regression occur in quite a number of people.
Well, it's happened to me too. I've had regression, but you're talking short-sighted.
Yeah.
So I've had,
well,
one's improved and one's...
Yeah, but that's different. The short-sighted, long-sighted is a bit different. I'm talking about corneal shape now. Yeah, right. Okay, interesting.
But yeah, I mean, it's sort of, the research out there shows that, you're most likely to progress when you're young. But if you've got bad allergies and you're an eye rubber, I've seen people your age progress.
Absolutely.
So, it's really making sure you are having regular reviews. If there is progression or changes, that'll be picked up.
It's interesting about allergies. I think this is probably the first time that I've really heard a lot about allergies being linked to this. How strong is the link? Is it you're in a dry area, if you're working in the garden, let's say, is that what you're kind of referring to in allergies, or what are you referring to?
It's generally like, in young kids, there's a condition called vernal keratoconjunctivitis, and it's a really severe form of allergy that's constant. It's not just sort of getting the occasional little bit of allergy. So it's kind of a constant allergy. We, think it's related to the inflammation and possibly some eye rubbing. So you don't need to be worried if you just have an occasional bit of allergy that things are going to get worse. There's also there's an adult form of that condition that causes quite severe allergy, and they're more likely to progress with keratoconus. So it's quite a, we don't believe just having very occasional seasonal allergy is causative.
I might just ask Stephanie as well about other associations with keratoconus, like sleep apnea.
Yes.
Heart valve issues, because I think that's an important topic.
Yeah, I think sleep apnea, that's if I see somebody who comes in and they're sort of, after the age of 30 and they've developed keratoconus, then I ask them about their sleep. And, particularly 40, 50, if they've got new signs of keratoconus, then often they do have a background of sleep apnea, and they're like, oh, my sleep's terrible. And, you send them off to the sleep study and they get that fixed and they feel a lot better, and sometimes their keratoconus can stabilize, or, it can be a crossover condition, pellucid. So it is important to bear in mind that keratoconus sometimes can be a marker for other systemic diseases. And, there's various connective tissue diseases, because your cornea is basically collagen that it can be associated with. Fortunately, they're less frequent, but they do need to be considered.
What about things like diabetes?
Not that I know.
No. It's kind of like, there's Down syndrome, that's another common one. A thing called Ehlers-Danlos, where you've got connective tissue disorder. It's sort of a range of less common things. Mitral valve prolapse.
When you have a cornea that is misshaped from degradation or scratching, and it's thin, is there a clinical point at which the only option is
for sure.
And is that the number? Or?
No.
No, it's a consideration of a number of things. So it's like, well, you know, the patient's age, the vision in the other eye, the patient's hobbies. You know, if they're a top-ranked taekwondo person, maybe they're not going to do it if they can see well out of their other eye. So, you know, it's based around their function, what they need to do, whether they can't do what they need to do anymore. Technically, a graft can be done on any cornea. So it doesn't particularly matter what the cornea itself is like to technically have a graft. It's more the need of the patient. And that comes down to the vision in that eye, the vision in the other eye, the social circumstances, the medical history, and whether they've failed contact lenses and glasses.
But isn't there a judgmental thing in terms of, you know, you can live with one eye, that's all right, you can't. I mean,
it's the patient judging it. It's not the doctor, it's the patient. You know, like I've got patients and you can say, look, you know, we could do a graft in your other eye. And they're like, no, I'm perfectly happy. Why would I want that? I want to travel the world. I don't want to get rejections. I want to keep doing kickboxing. So it's not the clinician making the judgment. It's a discussion between the clinician and the patient to arrive at something that suits that patient's life. Because once you've had a graft, your eye has kind of changed and you've got risks of rejection for the rest of your life. If you get hit in the eye, you can lose the eye. I mean, if grafts can be sight saving. They're an important tool in keratoconus. But you know, you do have to have some patient selection around it, and that is a agreement between the clinician and the patient.
No matter how degraded, it can still be fixed with contact.
Well, not necessarily, but it's whether whether the patient wants perceives a benefit from getting it fixed. But it's the risk versus the benefits of the graft, because you know, after you've had the graft, you've got 2 years of recovery. You've got to come and have lots of visits for, you know, stitches can get loose. And so not everybody is actually up for that if they're functioning okay. So some people, yes, have one eye that's quite badly scarred, the other eye 20/20 vision, and they're just not motivated to get the graft. The other thing after a graft is you might still need a contact lens on that eye that you've had the graft in. So it's not, you know, there's still things to be done.
Yeah, I basically say you just get on and off the merry-go-round. So if you're off the merry-go-round at the moment, don't get on it. You know, I mean, it sounds stupid, but don't go looking for trouble. You'd be surprised how one eye you can function quite well. I say to people, with one eye you can function at least 80% capacity, at least 80%. You lose the second eye, then you're at 0%. So, but, you know, just jumping in and having procedures and even contact lenses. Like I said, I get patients that come in, and I'm a contact lens practitioner. And the first thing I'll do is see if I can get a decent pair of glasses for them. Because I think that's an easy option. You get up in the morning, you whack them on, and off you go. Contact lenses, as you know, have got dramas.
Might just...
Please.
From a patient perspective, so I had the gas permeable lenses for several years, and that was absolutely amazing for my quality of life. Through pregnancy, childbirth, my keratoconus seemed to sort of stabilise, and then it went very, very quickly downhill. And I can't remember what the figures were on my eyes, you know, the steepness of the grafts and things like that, of the corneas at the time. But it got to the point where they just said, look, you're getting so many ulcers because we can't fit you properly. It's now the time that we have to discuss with you what you would like to do. And this is how it was put to me. And there was no real option in my head. I thought, well, I can't wear the contact lenses. If I do, I can maybe last an hour. I couldn't drive anywhere because my sight was so poor. So, you know, I went on the list. I waited 18 months. I got my first graft. My first graft didn't take for 4.5 years. It then rejected it. You know, it was a disaster. I then had an amazing surgery the second time round, and the next day I could see out of that eye. And that, I kid you not, that was absolutely amazingly unexpected from my experience. I didn't want to go down that road again, but I had something that was so scarred and useless that I wasn't going to be able to, you know, live with it. And then a year later, I had the other eye done, and that had its complications as well. As Stephanie said, that the stitches issue is for me always meant infection. Yeah. So, but once all the stitches have been removed, I'm here today with almost 20/20 vision and
a long journey.
And a very long journey. And sorry, I'm so grateful about it. But you know, the scleral lenses, when my optometrist showed me this scleral lens, I just about ran out of the building. I'm like, but I have 2 eyes. I don't need another one. This is what it looks like when they hand it to you. They said, just try it. And I said, okay, because I trust you, I'd had it for so many years. She was amazing. And she said, just sit here for half an hour, 2 hours, however long it takes, Michelle, and we can try and fit you properly and we can get something that's comfortable for you. And when I finally went home with my scleral lenses for the first time, I started at one end of the dining room table, and by the time I'd finished trying to practice putting them in, there was solution everywhere. My hands were being washed every 5 seconds. The tissue box was all strewn across the table. By the time I ended up on the last chair, I'd finally got the right eye in. But I'm very good at doing one rather than the other, actually. And but that gave me freedom at night time to drive. So I was then driving by day, but I couldn't drive at night until those scleral lenses kicked in, and I wasn't playing in orchestras because I couldn't share a stand with anybody. But now I can do it all. It is a decision. You know, when things were really bad for me, it was like, I don't want to continue going through surgeries and things anymore. Years and years and years and years of surgeries. For what? In the end, for pain. I was actually willing at that stage to you know, deal with legal blindness, and there's a lot available for people who are legally blind. So I had to start thinking, well, I'll have to learn bluegrass music, which is all improvised, and it doesn't set my heart on fire, but at least I'll still play my instrument. Yeah, I mean, that's my personal experience of it. So both surgery and, you know, all of the amazing lenses and things that I've had have given me a better quality of life. But it's not easy, and it's something that I wouldn't take lightly to suddenly, you know, go into surgery. So, yeah.
I don't know if it helps anyone else, but I have one scleral lens. Jim gives me, that's right, Jim, that's what it is.
Yep.
And I usually give it in first go. Yeah.
You've got big eyes, but.
I found a little tip, I don't know if you agree with this or not, but I found a little tip. I just get the little, I call them gauze tape, the little rubber thing.
Yep.
And I just get the pressure on the lens and do the first blink, and then it's fine, just hold from there away. It doesn't pop out to do the first blink.
Yeah, look, it's tricky. Everyone's got different eyes. I mean, what I tell people in the end, you'll develop your own technique. And I don't care if you do it standing on your head, but get it in there without damaging your eye. I also, just one more thing, the pregnancy and things kicking on.
Yeah.
There's something going on there too, right?
It has been reported that keratoconus can get worse in pregnancy. And I have seen some patients with that. So that's another discussion about, you know, whether people should have cross-linking before they get pregnant, because once they're pregnant, you can't do a procedure. Mm-hmm. Now, we have some refreshments and last question, yeah?
Sorry, I'm a parent of a son that's just been diagnosed with breast.
Yes.
So we're all discovering all this. In terms of what we can do to help it not progress, the eye rubbing, I mean, we went further with my son's mates, we said you can punch him. So trying to stop that.
Yes.
In terms of the glasses, he's been prescribed the glasses now, but he's now saying, you know, 17-year-old, no, I'm fine, I don't need my glasses. Does help wearing the glasses, even when he thinks he doesn't need them help, or is that you leave it to his judgment, or, you know, because, you know, one of those compensating,
as long as his
glasses help, and therefore.
Does he drive?
Yes.
Yeah, well, I'd be forcing him to drive with the glasses.
Yeah.
You know, I've got children, and I'd want to make sure that they've got the best possible vision driving. But if he's not driving and he wants to walk around with slightly blurry vision or blurry vision, I mean, it's not going to influence the keratoconus in any way whatsoever. Yeah, so that answers your question. Yeah.
Second, absolutely. Yeah, last question. Yes, thank you.
Just the same site registry.
Yes.
Obviously, last year.
Yeah.
One of the authors said, "Oh, we'd like it to be good in that registry." But I got the impression that it was mainly for people who were for whom cross-linking would be relevant.
No, we were actually, because we're trying to learn about the natural history of keratoconus. And so, you know, if you've had corneal grafts, it's not so relevant because you know, the cornea is is being replaced with grass. But we're trying to learn about, you know, what's happening, because, you know, because this is what people are saying, like, well, am I going to get worse? If I rub my eyes, is it going to get worse? What about allergy? We actually need answers to those questions. Okay.
So, numbers in the form, I guess.
That's it.
Thank you. So,
yeah, by the way, it said previously, I wear hard contact lenses. I don't have I've got reading glasses. I don't have a pair of ordinary glasses. Tried the idea of one stage, I wouldn't mind a pair of glasses just around the house. What I do is I get up, put the lenses in at the last minute before I leave the house, or before I get on with my day. So I have brekkie and have coffee and brekkie and looks around the house, whatever, without the lenses. I'm focused here, clear focus is 100 millimeters. But if you know where everything is, you can see black and white, you can see where things are, no brekkie, all the jargon, all that sort of stuff. And if I'm going to go out if I'm going out for the day where I'm going to be exposed to dust and wind and bright sun and potential dry eyes and so forth, I'll wear piggyback lenses. I wear piggyback on the left anyway. The right eye, I've only got 3 lenses at the moment, even though I ride a bicycle with me. In a tricky situation outdoors, hard lens on its own will give you trouble. Put a low power soft lens underneath it, and you're in curvature pretty much. You can't swim though.
Thank you very much. Yeah, so I'd just like to thank everyone for coming, but most importantly, I'd like to thank Joy and Anna if you'd like to come up onto the stage. And we've got some little thank you presents, and I really enjoyed hearing their stories. I thought they both spoke very well, and it was absolutely lovely to hear their experience, and I'm sure you would have gained from it. And as we said before, Anna's come all the way from Melbourne. I was there on Thursday last week. It was very cold. So I think we're going to choose between traffic with
no traffic.
Yeah, with no traffic.
Let's choose the streets and then I went around. Here I'm like, why are you taking me in the opposite direction?
It's a choice between traffic or weather. Okay. Did you want to? And also thank Jim, who I really enjoyed his talk, and I learned something there as well. I like the rules. And I think there's lots of pearls of wisdom there, and it is something where you develop a lot of expertise rather than specialisation. And lastly, I'll invite Michelle just to say a few words in closing. She's been the inspiration for us to get this event going every year, and I always enjoy catching up with her throughout the year to sort of plan what we're going to do. And she always comes with such great enthusiasm, and shares her experiences, which I find very very valuable, and I'm very grateful and thankful for it.
Thank you very much, Stephanie. As I said, this is about supporting each other with something that's not always a very easy condition to have, but it's always been a really amazing opportunity for the last 4 years to be able to have such support from Save Sight. And I'd like to also say thank you to Dr. Alex Verdi as well for his technical support and putting on the webinar. We've got out there larger than just this room. It's very exciting. And Himal, it was wonderful to meet you this year. Good luck with all of the work that you're doing, and thank you again for making this possible as part of this team. So can you please all join us out and have some refreshments? This is the time we get to talk to each other about our experiences, and I think that's probably one of the most valuable parts of the evening as well. So again, thank you all for being here. That was great.
We say bye to the webinar. Bye.
Thank you.
Oh, okay.
Thanks, everyone. Thanks for coming.